I am pleased to extend a very warm welcome to our chairpersons, Dr. Satya Prakash Yadav, Vice President, API Haryana. Sir is not here. Dr. MPS Chawla, Professor and Head, Department of Medicine, RML Hospital. Dr. Rajesh Madan, Senior Consultant and Clinical Cardiologist.
So I think my co-chairs are, I think, not here. So I'll take the. I think we can start the session, and I don't have the list. Can you provide me the list, please? So the topic of the session, the first session is by a very renowned personality in this field, Dr. Sanjay Kalra. I welcome Dr. Sanjay Kalra for delivering the session, particularly on non-steroidal MRAs, a new chapter for the management of CKD in diabetes. Dr. Sanjay Kalra is Chief of Endocrinology at Bharati Hospital, Karnal, President Endocrine Society of India, Vice President of South Asian Federation of Endocrine Societies, Associate Editor of Diabetic Medicine UK, and Section Editor of Diabetes of ESI Manual of Clinical Cardiology, and Section Editor of Endocrinology of API Textbook of Medicine 11th edition. Speaker in various national and international forums, vast clinical experience, and principal investigator of many global clinical trials. We know we have heard Dr. Sanjay sir from years and years, and he's a very big name in this field. Welcome, Dr. Sir.
Thank you, Chairperson, sir, and good evening, everybody. Last 2 days, yesterday and today, we've been discussing so many things about metabolism. People in this hall, people in other halls have spoken about the brain, the pancreas, the liver, virtually every organ system that you can think of.
Second is.
But when you look at the alpha to omega of metabolism, where does the buck stop?
I'll take care.
It stops at the kidney. It's the kidney which excretes whatever has to be excreted. It is the kidney which makes sure that each and every drug that you take, each and every food that you take is metabolized and managed properly. So without the kidneys, we cannot function. And we have bright young residents from AIIMS New Delhi, so the question to them is, how many kidneys does one have? 2, that's good. So it means at least one person is awake. And then another question, how heavy is each kidney? Oh, shabash. Let's try again. I mean, सब लोग 100 किलो के थोड़ी ना होते हैं. 200-ish, maximum 250. Chalo, but we'll move ahead. You still have a couple of more exams to pass, so be careful. But we'll continue with that. The point is that the kidneys are important. Now, when we are in first prof, we know everything there is to know about anatomy and physiology. But by the time we reach practice, we have forgotten many things. And if you happen to enter diabetology, then things become so straight-jacketed, so tubular for you. Everything becomes acute or chronic. And in chronic, it becomes macrovascular, microvascular. Your teachers, they इतना डंडा मारते हैं, इतना रट्टा लगवाते हैं, macrovascular, microvascular, macrovascular, microvascular. By the end of that training, you realize that the kidney is a microvascular organ. But the point is, you forget कि और चीज़ें भी हैं kidney में, apart from the vessels. Similarly, for the heart, you are told that coronary artery disease is a macrovascular complication, and you forget that there are other parts of the heart also. We first prof में pericardium, epicardium, myocardium वो भी तो सीखा था, but you forget that. And then you have to be reminded in a CME that heart failure is a separate entity. Now, a lot of discussion has taken place in the last 1 to 2 decades about heart failure, about the heart, about various organ systems that diabetes impacts. But the kidney always gets, shortchanged. Things are still better than before because in the time of Aristotle, it was thought that it is the bladder which is the excretory organ of the body. They thought that kidneys are just appendages of no value and all the work is being done by the urinary bladder. So at least we have moved a long way since then. But still, in spite of all that, our patients continue to suffer. In spite of all we do for them, with the best of intentions, 1/3 of all patients with type 2 diabetes will go on to developing CKD. And CKD, chronic kidney disease, can occur in spite of good glucose control, in spite of good blood pressure control, in spite of good metabolic control. So, complications like retinopathy and nephropathy are actually duration dependent. They are duration dependent because they are duration dependent on two things. One is the quantity of life, and second is, or the duration of life, and the second is the duration of diabetes. The third is the duration of uncontrolled diabetes. So, three different aspects. And the natural history may vary, but still, most of our patients will progress to kidney disease, chronic kidney disease, and some of them will progress to end-stage kidney disease. Now the question comes, so we have seen the status of anatomy. हमारे young shining India में, future of India में अब एक physiology का question आ रहा है. So Shubham, would you want to tag anybody? Somebody whom you love in this hall, somebody whom you don't love, who would want to answer a question on physiology? हाँ, छू दो उसको. So physiology. What is the normal EGFR of an adult human being?
Above 90.
Oh sir, वो quiz वाला बच्चा है उसने MD. Okay, above 90. So now नाम तो बता दो अपना हीरो. हाँ? Okay, so Jagbir, what is the rate of fall of EGFR in a normal human being in every decade of life? एक बता दो. 10, ठीक है. That's quite good actually. So 10 ml per minute per meter square is the fall in EGFR per decade. Starting from which decade? Third लगा लेते हैं. So point is that if you are in third decade and your EGFR is, let us say, 110, by the time you reach fourth decade it will be 100, and if you live till 80 or 90, as it is, you would have entered a CKD stage. So it is duration dependent. It is dependent upon duration of life. It's not just about kidney disease. It's just not just about a number. It's also about outcomes, cardiovascular outcomes, because as albuminuria goes up and or as EGFR comes down, cardiovascular events go up. We do try our best. So we give good glucose control. We offer good hemodynamic management. We use RAS blockade. So good metabolic control, good hemodynamic control. In spite of that, CKD occurs. There is a residual risk. The term residual risk is used for heart disease. When you say, I lowered the lipids as much as I could, but still there was a risk of heart disease. We highlight that, but we forget to highlight that there is a residual risk in the kidney as well. And actually, in spite of giving good hemodynamic and good metabolic control, we still have residual risk because we are not able to focus on the renal parenchyma. And if each kidney is, let us say, 200 grams heavy, it is 150 to 2 grams actually, that is the correct answer. So if it is 200 grams heavy or 150 grams heavy, almost 90% of that bulk is going to be from the parenchyma. So you keep on focusing on the tiny glomeruli, on the microvessels. That is good, that is right. But if you ignore 90% of the kidney mass, that is the parenchyma, you are not going to get optimal results. And this is because in the parenchyma, you continue to have inflammation and fibrosis. So it would be a good idea, therefore, if we had a drug that could actually handle the inflammation and fibrosis of the kidney. There is no existing drug that is able to do this until recently in the West. And we have had a lot of advances, GLP-1RA, SGLT2 inhibitors, but they have focused mainly on the metabolic and hemodynamic parameters. So this residual risk is important. We are all aware of it. So far, we have not been able to attack it or address it. But now we have a novel drug, which is Finerenone. And Finerenone is a nonsteroidal drug. That is one plus point. It is selective. That is another plus point. And of course, it is a mineralocorticoid receptor antagonist. So it antagonizes the mineralocorticoid receptors. So if you have someone with sympathetic overdrive, with hypertension, someone with excessive discharge of aldosterone, you would want to bring it down. And what drug do you use traditionally in maybe in resistant or actually in refractory hypertension? Spironolactone. So that is the best in class that we had so far. But spironolactone has many side effects. It acts not only on the mineralocorticoids, it also acts on the androgen receptors. It is an antagonist. So it will end up causing loss of libido. It will cause gynecomastia. It is actually used in transgender health to cause breast enlargement. It also acts upon the electrolyte balance, and it can cause hyperkalemia. So these are some negatives. Of course, we use this to positive as well. It is commonly used off-label in polycystic ovary syndrome as an anti-androgen. It can also be used, though it is not all that effective, for what you call chemical castration. If you want to, in a repeated sexual offender, you might want to use spironolactone. Though of course better drugs are available. GnRH analogs would be a better drug of choice for that. So this is how Finerenone is different from spironolactone and also from eplerenone, which is used rarely. No side effects and actual full potency against the mineralocorticoid receptor. So now it stands to reason, if you have a drug like this, perhaps you can use it in resistant and refractory hypertension. Perhaps you can use it in all kidney disease. Studies are ongoing. So FIND CKD is a study that is ongoing for non-diabetic kidney disease. But we have very good data for Finerenone in chronic kidney disease related to type 2 diabetes. So let's use the term DKD, diabetic kidney disease. And do note that DKD can be albuminuric, usually it is, but it can be non-albuminuric as well. So you might have albuminuria, you might have fall in EGFR, you might have both. And two studies, Fidelio DKD and Figaro DKD, have been performed. In both of these, the endpoints were similar. It is just that in one study, a particular endpoint was taken as the primary endpoint, and in the other one, it was taken as a secondary endpoint. And they just swapped. So Fidelio, Figaro, the same endpoints. Almost the same inclusion criteria. But when you look at the studies like maybe EMPA-REG or like Canvas, you will find that the inclusion criteria talk about macrovascular diseases. So it is a macrovascular assessment of the patient, which is telling you whether that person can be a participant or not. Here it is microvascular. So CKD was defined according to EGFR or albuminuria, and in Fidelio DKD, it was also defined according to presence of retinopathy. Why they chose retinopathy? Because of something known as reno-retinal association. Both are microvascular, both are together. And what they assumed was that if our patient has retinopathy, whatever KD, whatever kidney disease is there, will also be because of diabetes. Stable patients were chosen. Non-diabetic kidney disease was excluded. And both the studies were randomized, double-blind, placebo-controlled, event-driven. And in both of them, we have already said the endpoint was related to kidney function progression. So here, time taken to onset of kidney failure, a sustained reduction in EGFR, kidney failure defined as end-stage kidney disease or an EGFR less than 15, 15. So similar situation for Figaro DT, only primary and secondary were interchanged. And in these two trials put together, Figaro and Fidelio, more than 13,000 participants were enrolled. So a huge study, both the studies put together. All sorts of patients were taken. Like we've already mentioned, some of them had albuminuria, others had a low EGFR, some had both. And you can see a vast spectrum of patients included. So throughout that spectrum of EGFR, up till CKD stage 4, EGFR and albuminuria, all participants were included. And this represents what you and I see in our clinics every day. The baseline characteristics, long-standing diabetes, 16 years, hypertension, fairly controlled diabetes but not very well controlled, and normal potassium levels. All sorts of comorbid conditions. So if you have a patient who has stable CKD and who has any other kind of disease, macro or microvascular, even heart failure, that patient could have been included in these trials. EGFR and albuminuria we have mentioned repeatedly. Concomitant medication, all sorts of concomitant medication patients were included, irrespective of whatever they were taking. Now, mineralocorticoid antagonists come in the classification of diuretics, potassium sparing diuretics, that is the pharmacology classification. But still, patients who are on other diuretics were also included to the tune of around 50%. SGLT2 inhibitors are in vogue now. Patients on SGLT2 inhibitors were also included to the tune of 4 to 8%. Why is there a difference? Because the uptake of SGLT2 inhibitors has increased markedly over the world in the past few years. GLP-1RA patients were also included. Those on insulin, those on oral glucose lowering therapy, all were included. So in summary, the kind of patients that you see, the kind of patients that I see, that we all see, all these were included in Figaro and Fidelio. What did we see? We saw that the drug was effective over and on top of maximally tolerated RAS blockade, which is standard of care. Finerenone was able to significantly reduce the primary kidney outcome by 18%, p-value of 0.001. And what is primary kidney outcome? That is kidney failure, sustained reduction in EGFR of 40%, or renal death. So whichever value you want to look at, the EGFR, the serum creatinine, or renal death, or need for dialysis, all this was included. So this was from Fidelio DKD. Albuminuria also came down, and it was a very rapid reduction. Within 4 months, albuminuria reduced by 31%, which was statistically significant. And within about 12 months, just within 1 year, you could see the curves diverging. You could see a difference in long-term outcomes as well. Not only kidney outcomes, even CV outcomes reduced, and this was by 14%, again statistically significant, p-value of 0.03. So if your patient asks you, Dr. Saab, do you have a medicine which will help keep my husband's or my spouse's heart safe and kidney safe? Then you can confidently say yes. Will it benefit my spouse's heart and kidney? Again, the answer is a confident yes, and this is based on Fidelio. Some of you will ask, what about use over and on top of SGLT2 inhibitors? So like we have shown, around 5% of the participants were on SGLT2 inhibitors, and when a separate analysis was done, they found that the same effect, the same improvement was seen in those without SGLT2 inhibitor therapy and those with. So whatever other glucose lowering therapy you are using, Finerenone can be added. In Figaro, here what we saw is that the primary composite outcome, which was CV outcomes, this was reduced by 13%, statistically significant, p-value of 0.026. But in Figaro, the reduction in EGFR, that reduced. So you could help the patient prevent a reduction in EGFR if you took a cutoff of 57%. But if you took it as a 40% reduction in EGFR, then there was no statistical significance with that. But Fidelio did show that significance. Hyperkalemia did increase, but the clinical impact was low. So again, a safe drug, and the hyperkalemia is much, much less than what you would see with spironolactone. Overall, very safe, a modest effect on blood pressure. HbA1c and body weight did not change, so metabolically neutral from the glucose point of view. No impact on acute kidney injury. Something very important, because when you look at drugs like SGLT2 inhibitors, drugs like Vimada, and also drugs like RAS blockade, there is always a risk of acute kidney injury that you run. And of course, the side effects related to anti-androgenic effect, those were minimal. They were just similar to placebo. Overall, a very well tolerated drug. It is not available in India as of now, but it should be in the market in a few months, within this year. And what we hope is that we will be able to follow international guidelines now, which tell us that all patients with CKD, diabetic patients with CKD, who are at increased risk for CV events or at chronic kidney disease progression, which is everyone, all of these should benefit from a nonsteroidal mineralocorticoid receptor antagonist, which is Finerenone, the only one in its class. If a patient is not able to use SGLT2 inhibitor because it is not tolerated, because it is not safe, because of various side effects, again Finerenone would be a good add. This would be not for glucose control, it would be for vasculometabolic control and for viscerometabolic control. So this is something that I have faced. I was always so vascular-oriented. It has taken me time to actually understand that there is much more to the heart than the coronary arteries. There is much more to the kidney than the glomeruli. And not only vascular, but also viscerometabolic benefit is what we get. And this is what is proven by the Fidelio DKD and the Figaro DKD results. So this is what we had to share today. A new drug backed by very robust evidence, something that should be available with us soon, and something that will be able to help our patients by protecting their kidneys, by preventing the progression of chronic kidney disease in persons with type 2 diabetes. Thank you.
Thank you, sir, for a wonderful conceptual and clear-cut talk and giving us a concept of this new molecule that is the Finerenone, which is going to be launched in the market very soon. And I'm really happy to see the renal benefits, the cardiovascular benefits with the 2 big trials back up. And at the same time, this molecule doesn't cause hyperkalemia at all. And there are no side effects of this spironolactone which are there, which we've been using for years. I think it's a wonderful molecule, and the house is open. If anybody has some questions, please go ahead.
So we can conclude that in microalbuminuria, this will be good drug to use in all patients.
In
CKD with microalbuminuria,
yes.
this is a drug of choice, sir.
CKD, even if the patient has CKD with microalbuminuria or with normoalbuminuria, the drug is effective. That is according to evidence. So even in non-albuminuric we can use.
And by parenchyma, you meant the part of the kidney which is having tubules, both proximal and distal.
The tubulo-interstitial compartment.
Okay, leaving the glomeruli at the cortex.
Yes, sir.
Thank you.
So because of that, you can use it along with RAS blockade, because the RAS blockade that will act at the level of the glomeruli. You can use it along with SGLT2 inhibitors. They will act at the level of the tubules. Yes, sir. That is also there, and the data is in general either favorable or neutral. So what you are raising is actually that will help us compare SGLT2 inhibitors versus Finerenone. There is no direct head-to-head evidence, but using these network analysis have been done. And what they have found is that from a heart failure point of view, SGLT2 inhibitors are more beneficial. From a CV outcome point of view, SGLT2 inhibitors are more beneficial. From a renal point of view, it is Finerenone which is more beneficial. Sir, it was not included. It was not there. No, not an endpoint.
What would be the reason of potassium sparing part of this?
It is highly selective. Yeah, I think it acts more on the inflammation and the fibrosis. Yes, probably that is the reason.
I have 2 questions, one for the endocrinologist, one for the cardiologist. So one is that suppose it gets introduced, so would you like to put it as an add-on to SGLT2 inhibitors, or would you like to start upfront both of them together for maximum renal benefit?
And the second question?
And the second for sir is, as far as heart failure management is concerned, would you like to replace Finerenone with, replace spironolactone with Finerenone as part of guideline-directed medical therapy for management of heart failure once it gets introduced, or would you like to use both of them together?
See, sir, please continue.
So, question raised is really valid, and actually I would appreciate the insight that is going into this question. Whatever drugs you use, you can use them simultaneously or sequentially. General dictum, and I will request Dr. Bhatia, Dr. Chugh, senior members of the house, whenever you are making a change in a prescription, either it is an initiation of a drug or it is interchange of a drug. Initiation, interchange, or maybe intensification or de-intensification. If you are in the ward, if you are in ICU, then it is an acute crisis. So you might want to start 10 drugs together, which can be 1 vasopressor, 1 hydrocortisone, 3 antibiotics. And that is what the ICU says. But if you are in the OPD, general dictum would be do not make more than 1 or 2 changes. If I make 3 changes in my prescription, let us say I start SGLT2 inhibitor, and then I start Finerenone, and maybe I start GLP-1RA. all three together. So I am not going to do that. I am sure even Dr. Sameer will not have any patient on all three together at the same time, starting on the same time. If I do all three, 100% surety, patient will come back within 2 days and say, Doctor Sahab, आपकी दवाई बड़ी गर्म है. And दूसरा, even I will also not be able to know if there is a side effect, if there is an issue, which drug is causing it. So a general dictum would be to make minimum changes on any one particular day. Now, which of those changes should I make? That will depend upon my main priority on that day. If my main priority and my patient's priority is glucose control, then I would maybe go for insulin or SGLT2 inhibitor. Suppose my patient's main priority is prevention of hospitalization for heart failure, then I will focus on SGLT2 inhibitor. And if my patient's main focus is CKD, so when you are in medicine, patients will come to you with symptoms or signs or laboratory reports. These are three things. But allow me to add one fourth thing, and that is concern. What is your patient concerned about? She is concerned that I do not want to get admitted in the cardiology setup again. Twice मैं डॉक्टर साहब की शक्ल देखा हूँ, बहुत हैंडसम है, बड़े सुंदर हैं. Thrice I do not want to go. Then I will add Finerenone. Then I will add SGLT2 inhibitor. And if the main concern is CKD, Doctor Sahab, abhi to my creatinine was 1.2, now it is 1.3, now it is 1.33. It is so easy to blame the lab. You can do that if you want, but here I will add Finerenone first. So that is in general. Now coming back to your question, what you were asking was simultaneous versus sequential. So from a very conservative point of view, I would say I would bet for sequential use. But sequential does not have to be after 3 months, 6 months. It might be after 2 weeks. Let me start ramipril or telmisartan today along with hydrochlorothiazide. If when my patient is stable, after 2 weeks I will start Finerenone. After another 2 weeks I will start SGLT2 inhibitor. But the order will vary according to concern. So I hope I have been able to satisfy you, Shubham, and Dr. Bhatia sir. Dr. Chuk sir, am I right, or is there something you would want to add? Because question बहुत genuine था लड़के का.
His second part is not still answered.
वो
In patient of heart failure,
हाँ.
we have now the latest 3 ARNI, beta blockers plus mineralocorticoids. And we will choose these mineralocorticoids as compared to aldactone or the other thing.
Yes.
Because of potassium sparing effect. Because once we start to treat heart failure, we check urea, creatinine, electrolytes for potassium. And if this is a drug which will tell us that potassium is not to be raised, we will prefer this as compared to aldactone.
Huh? It's not there.
Not there.
Huh.
Heart failure, as you said. By marrying the kidney, heart failure reduced reduction in the 5-3 data wasn't there in the endpoint.
नहीं, वो सर क्या कह रहे हैं कि between aldactone and Finerenone he will choose Finerenone. That is what Dr. Chuk sir said.
But my point is, if it was a heart failure reduction we are aiming at, and we have data with spironolactone as rails and secondary subset of top cat. Here we don't have a data at all with Finerenone. What are your comments?
I think I agree with sir. Since the future might be of Finerenone, but once we have a data in hand,
Yeah.
so far as of now till date, we have, as sir has very rightly said, we have ARNI in hand, we have SGLT2 inhibitors in hand for the management of heart failure. I agree with the sir, sequential adding is very important, so things are in our hand, we can manage and modify the things at any moment. And the third is, since the data with spironolactone is there in our hand and we are using this molecule from years and we are comfortable with it as in the management of heart failure, so I will be using till date till we have more and more data and we are use this molecule in the real world and see how this behaves. And as of now, prima facie it looks very convincing, and since it doesn't cause hyperkalemia, with other molecule, this molecule will likely to show that this will behave better in the management of heart failure.
Yeah. Now let us attempt the second part of the question. First one, you are aware of the philosophy now and how to approach in the OPD. Now the second one, if you have a patient with heart failure, what is the main concern? Is it only heart failure? Is it metabolic dysfunction? In the last 3 months, there have been 4 episodes of biochemical hyperkalemia. There have been 2 episodes of dehydration also. It is the month of June. There is a risk of heat exhaustion. Is it there or is it not there? Third angle, glucose control. Glucose is perfect. You don't have to worry at all. Or you are struggling with glucose. कुश्ती लड़े जा रहे हो. कभी basal bolus, कभी premixed, कभी कुछ. Now, depending upon that, you will have a phenotype of your patient. If you are concerned about hyperkalemia, and it has been an issue in the past, you are concerned about acute kidney injury, then even though the data is there for spironolactone, we are happier with Finerenone. But if that part is so clean, बिल्कुल साफ सुथरी सी slate है, then you will use spironolactone. This is only with diabetic. Non-diabetic was excluded. Yeah. Yes. Now, if it is a diabetes issue, and patient needs better glucose control, then SGLT2 inhibitors will jump to the top. Sacubitril valsartan will go behind. And whatever some experts may tell you, I don't think any of us would want to start simultaneously on the same day. Unless you are able to call your patient twice a week.
Absolutely. Very true, sir. Very
It also depends how far away your patient is coming from.
true. Absolutely.
If so, glucose control, metabolic control, and then of course
Kalra
heart
sir.
failure. All these will act.
Can we?
आगे चलते हैं.
I will-